Hello, everyone. Welcome to the Anesthesia Clinics. This talk has been prepared by Dr. Munasshira Sayeed and Dr. Samidha Waradkar from Lilavati Hospital. Anesthesia types can be broadly classified into two, the regional anesthesia and the general anesthesia. We have discussed topics within the spinal and the epidural anesthesia. Today, we are going to discuss about general anesthesia. Okay, so it can be given in two ways, either by inhalational or by intravenous mode. Okay, so there is general anesthesia, there is sedation with monitored anesthesia care, and there is local anesthesia. We are going to discuss specifically about the intravenous general anesthesia. That forms in two parts, induction and maintenance. So these drugs can be traced right back to 1656. Civil Christopher Wren and Daniel Major's first experiments. Okay, so they injected IV using goose quill and bladder to inject wine and al into the dog's vein. That is how it all began, long time ago. So the most commonly used drug is, of course, Propofol. I think widely used all over the world because it is safest and has a very smooth induction and emergence. Less commonly used is etomidate. Thiopentone has been used for very long time historically also. Other drug is ketamine and midazolam. So let's start with Propofol, alkyl phenol derivative, 2,6-diisopropyl-phenol. Formulation most commonly used is 1% propofol with 10% soybean oil, 1.2% purified egg phospholipid added as emulsifier, 2.25% of glycerol as a tonicity adjusting agent, sodium hydroxide to change the pH, and EDTA was added for its bacteriostatic activities. On an average, it has a pH of 7. So what is the mechanism of action? Facilitation of inhibitory neurotransmission mediated by GABA-A receptor binding. Allosterically increases binding affinity of GABA for the GABA-A receptor, and they are not reversed. The actions are not reversed by the specific benzodiazepine antagonist flumazenil. Pharmacokinetics for the various your indications, you will have a different doses. For induction of general anesthesia, most commonly used is 1.5 to 2.5 milligram per kilogram IV dose, which is, of course, you use in titrated as you use it in elderly patients. Why, we'll see later. Maintenance of general anesthesia, you can use as an infusion form, 50 to 150 microgram per kilogram per minute IV, combined either in a balanced form with nitrous or an opiate, depending if you're giving total intravenous or in a balanced anesthesia. For sedation only, where you don't want a loss of your airway reflexes, you can use 25 to 75 microgram per kilogram per minute IV. And only for its antiemetic action, you can use a small dose of 10 to 20 milligram IV bolus, which can be repeated every 5 to 10 minutes, or start an infusion of 10 microgram per kilogram per minute. So in pharmacokinetics, about the distribution, it is distributed rapidly into all various fat stores, rapid onset of action, rapid recovery, less of after effects. As I said, there is very smooth emergence. Smaller induction dose in elderly patients as they have small volume of distribution. If you give higher dose, you are going to have more hemodynamic instability. You're going to land up with bradycardia, hypotension, which will not be a favorable action or reaction to patients who have ischemic heart disease or kidney disease and so on and so forth. Metabolism and excretion, it has an hepatic and extrahepatic metabolism. Most important, extrahepatic site, kidney 30%, conjugation in the liver, inactive metabolites eliminated by renal clearance and not affected by cirrhosis or kidney failure. So let's see now the effects at pharmacodynamics. First, starting with the cardiovascular, most common side effect is hypotension, that is fall in blood pressure. So there is a drop in systemic vascular resistance, which is due to the inhibition of sympathetic vasoconstrictor activity, fall in preload, and decreased cardiac contractility. It leads to impaired arterial baroreflex response. Risk factors are, of course, if you don't give as per the weight, if you don't titrate the doses, give rapid injection in elderly patients who are already having hemodynamic instability or having some cardiac issues such as low ejection fractions. Sometimes it causes gross drop in cardiac filling, reflex bradycardia, which is a vehicle response. Severe changes in heart rate and cardiac output common at extremes of age, patients on beta adrenergic blockers, and impaired ventricular function. Myocardial oxygen supply demand mismatch can happen again with higher doses. In the respiratory part, it causes profound respiratory depression. Is commonly, if you give an induction dose, will cause rapid apnea. Sub-anesthetic doses, it may just cause suppression of your ventilatory drive, so you may breathe more shallow with a lower respiratory rate, okay, and depresses the normal response to hypercarbia. Definite depression of upper airway reflexes much more than the thiopental, which allows smoother planes for intubation, endoscopy, or laryngeal mask placement in the absence of neuromuscular blockage. So places where you want to avoid, or if it's a shorter case, then you may avoid giving muscle relaxants. May cause histamine release. It is still not that common, but still in susceptible patients, you do get some sort of an allergic reaction. But it is still a safer drug compared to other drugs which cause more gross histamine release, but lower incidence of wheezing in both asthmatic and non-asthmatic patients compared with barbiturates or etomidate. Is helpful again in the lung issue because it causes bronchodilation due to direct action on the smooth muscle, not as well as halothane. In the cerebral component, the cerebral blood volume, intracranial pressure, and intraocular pressures. In patients with raised ICP, it can cause critical drop in the cerebral perfusion pressure, less than 50 millimeters of mercury. Okay, so basically, when you're giving, better to give preemptively some pressure so that the BP doesn't drop. Sometimes very early may cause muscle twitching and spontaneous movements or hiccups. Anticonvulsant properties, so safe in epileptic patients, has of course antiemetic effects and doesn't have any long-term tolerance. Okay, the most common uses are for induction, maintenance, sedation. In subhypnotic doses, you may use it for treatment of chemotherapy-induced vomiting, refractory postoperative nausea and vomiting, pruritus associated with neuralgical opioids. Commonly seen complications or side effects, pain at the injection site. Okay, it is irritant, so it can be reduced by using larger vein, doing it in a running line with fluid going on intermittently, adding lignocaine, sometimes adding ondansetron also is said to help to reduce the pain. May cause myoclonus, apnea, of course, much more than thiopentone, drop in blood pressure. It's basically a lipid emulsion, so you have to be careful in giving in patients with disorders of lipid metabolism. Rapidly crosses the placenta, but it is not so bad if you're giving patients, for a cesarean section. Supports bacterial growth, so you cannot, once opened, it has to be used or discard the remaining drug immediately. It may cause thrombophlebitis, especially if injected in a smaller vein on repeated doses, because it is a venoirritant. Okay, Propofol infusion syndrome. This is a unique thing seen only with use of Propofol, especially for long-term infusions. It's rare, but it may be lethal. Risk factors is poor oxygen delivery, sepsis, serious cerebral injury, and large Propofol dosages. Doses as much as 4 milligram per kilogram per hour or more than 48 hours. It presents with refractory bradycardia, which can lead to asystole. In the presence of metabolic acidosis with base deficit more than 10 millimoles per liters, rhabdomyolysis, hyperlipidemia, and enlarged or fatty liver. Other features which may be seen is cardiomyopathy with acute cardiac failure, skeletal myopathy, hyperkalemia, hepatomegaly, lipemia. It may be diagnosed on ABG and serum lactate levels. Clinically, you will see as like a greenish urine, and you will have changes in your hemodynamics. And of course, the way to diagnose this is, of course, on a blood gas. Okay. So the thing is, stop Propofol infusion immediately and then give supportive treatment to treat acidosis. And if it is very bad, you may need something to flush it out to help for your kidney protection also. Avoid in cases where your patient has a known allergy or to any component of Propofol. Disorders of fat metabolism, be careful where there is, as we mentioned before, in any kind of hemodynamic instability. and better to be avoided in early pregnancy and lactation. Thank you.